Hey everybody, this is Deepu Gowda, Course Director for Foundations of Clinical Medicine Tutorials. I want to take a few minutes to describe the mid-semester OSCE experience that is coming up. First, let's go over the goals. This is a formative experience. This means that you can't fail this experience. It's an opportunity to give this a shot, to try doing a focused history and physical in a short amount of time, 20 minutes. You'll receive a score, but it will not be part of your grade. So it's an opportunity to practice, get feedback, and very importantly, to self-assess your skills. This format is really based on Step 2 clinical skills. As you will soon learn, this is kind of a standard format of the focused history and physical that you'll see in several different types of educational settings. So let's think about the logistics. First of all, when does this happen? Please check your OSCE calendar. You are given a date and you're given a time. So please mark that down in your calendar and show up early. Get there at least 15 minutes early. It's in the Sim Center, which is the basement of the VEC building. Bring your white coats. Dress professionally. Men should wear a shirt and tie. Wear socks. And wear your white coat. Bring a stethoscope. You will be asked to log in to Beeline. So please bring your Beeline login and password. You'll need that to be able to have this experience. The rooms will have everything else you need, including drapes, the otoscope, ophthalmoscope if you need those, things like that. And you'll be given a blank sheet of paper. You'll not be able to bring in any pre-printed materials, no checklists and things like that, but you can definitely take in a blank sheet of paper. That's the same thing that will be allowed for Step 2 CS. So a couple notes just about simulation as a whole. We want this to be an immersive experience. Really treat the standardized patient as a patient. Don't try to second guess the testing scenario and what you're supposed to be hearing and all that kind of stuff. Just as much as you can, just pretend this is a real patient, given the time constraints and the objectives of the experience. And this is going to be confidential, so these video links will not be shared with anybody else other than your preceptors. And you'll have a chance to self-assess and share the experiences with your classmates as well. And so here are the general goals of the OSCE experience. Number one, foster a relationship. So we want you to be able to have a communication, develop rapport, and develop that relationship with your patient. Number two, gather information. Number three, provide information if it's necessary. So there's going to be certain scenarios in the future where the scenario is mainly going to be about counseling. So in that situation, of course, you're going to be eliciting the patient's perspective, but so much of it is going to be about also providing information. But always be thinking about whether there's an opportunity for that. Number four, make decisions with the patient's involvement. There may be further tests to do and things like that. So that's when you're going to be sitting down with the patient and thinking about next steps. There are decisions to be made. And the last part is support emotions. So the patient in any clinical scenario may be expressing emotion. It might be anger, it may be frustration, it may be sadness, it may be fear. Whatever it is, part of this experience also is to be alert and aware of the patient's emotional state, be able to name it, be able to bring it up as a topic of discussion, and support the patient through those emotions. Here is the structure of the mid-semester OSCE. You'll have two cases. Okay, so we're going to go ahead and give you the chief complaint of both cases so you can take a look ahead and think about what might be coming up for you. The first case is a 62-year-old patient with acute chest pain. So you can think about all the different diagnoses and the systems that could be involved for someone that's coming in with acute chest pain. And the good news is you guys have already done this in your focused introduction to the focused H&P at the beginning of the semester. So you have a little bit of a head start. So this experience is taking what you learned from that and now doing it on your own. The second case you get is going to be a 60-year-old patient with dizziness. So this week you will also be given an online experience where you can do an online case of a patient that comes in with dizziness. where you can explore the differential diagnosis, think about what history and physical could help you. And so this is going to be a great opportunity for you to do that online experience. Use that education, that knowledge, to then help guide your history and physical and decision making and thinking in the actual OSCE. So for both of these cases, you should have some preparation going into it. You're not going to go into it cold. For each case, you're going to get 20 minutes to do the history and physical, and then you finish that, you come outside, back to the computer, and then you have 10 minutes to do a post-encounter note. All right, so let's think about the encounter structure. First, you're going to step up to the door, and on the computer, when you log into Beeline, it's going to give you some instructions about what this patient, the patient's age, the patient's chief concern, and other pertinent details. You're going to write some of that stuff down. You're going to think about the differential a little bit for few seconds, and then you're going to knock on the door and you're going to come in. You're going to take a history. In this situation, since you have 20 minutes to be in the room, you can spend up to 10 minutes doing a history, 10, 12 minutes. Then you have a good 5 minutes to do a physical, and then don't forget you have to do a closure before you end that encounter. And that closure means sitting down, talking to the patient about what you think is going on, what you heard, from the history, what you experienced in the physical, and what you think could be going on, telling them about what the appropriate next steps are, seeing if there's any questions, seeing if they're okay with those next steps, and then leaving the room. And then you're going to step outside and do a post-encounter note, and I'll tell you about what that looks like in a second. First of all, introductions. You want to knock on the door. Come on in, ask the patient's last name. You want to introduce yourself, your first and last name, and shake hands. You should probably use Purell before you do that, because in real life, if you're going from room to room in a hospital or in a clinic, you want to really use Purell before you shake the patient's hand. Make eye contact and then sit down to start talking to the patient. When you start talking to the patient and do the history, use open-ended questions, okay? You should use at least 2 or 3 open-ended questions before launching into focused questions. So what do open-ended questions sound like? The first one is probably going to be, "Hello, Mr. Jones. Can you tell me what brought you into the clinic? Or what's going on today? Can you tell me what brought you in?" And then let's say he says, "Oh, I have severe toe pain." The next question is not going to be, on a scale of 1 to 10, how severe is your toe pain? That's a focus question. The second question is going to be another open-ended question, something like, "Okay, Mr. Jones, could you describe that toe pain for me a little bit?" Okay, and it goes on like that. And I would recommend 2 or 3 open-ended questions before moving on to focus questions. Once you do move on to focus questions, think about bold cards. That can be very helpful. Not all the domains are useful for every situation, but it's a really good structure for looking at the main dimensions of a complaint. Then you want to go on to pertinent review of systems. Okay, so you should be thinking already, what systems are really at play here, and what questions should I ask? Because you don't have time to ask a head-to-toe ROS. It's going to be focused. You want to ask a hypothesis-based past medical history. Ask, what other medical problems they have, if they've had other surgeries, what meds they take. You want to ask about that period, if they have any allergies. Ask about any family history that's pertinent to the complaint that you're experiencing, and pertinent social history. Ask about substance use. Ask about, who they're living with, what kind of job they have, and anything else that you think is pertinent. And don't forget to ask about the patient's experience. If someone says, "Yeah, I've got excruciating toe pain and foot pain," ask the question, "Gosh, this sounds like it's really, painful to you. Have you found this is really affecting your life right now?" And the patient says, "Of course. Hell yeah, it's affecting me. I haven't been able to go to work for the past week." Okay, so that's a really good question to ask in general. For every patient you see, tell me about how, what you're going through is affecting your life right now, is affecting what you're able to do. Even if someone's not working, it might be affecting what things they're capable of doing, and maybe they need to ask for more help on basic things like, washing dishes and doing the laundry or even bathing themselves. Who knows? So always a useful question. Couple pearls for history taking. Listen without interruption, address the patient's concerns, look for those nonverbal cues to look at the, especially emotions. Use simple language, avoid jargon, stay non-judgmental. If you're going to ask about sensitive topics, make sure to preface that by saying, look, these are questions that we ask all our patients, and this is going to be confidential and will only be used really for medical purposes, and it will remain on our chart. I'll discuss it with our attending physician, but it won't go beyond that. And summarize when you can, especially when there's a complicated history. It helps you get a sense of what's going on, and it tells the patient that you've been listening. You can certainly jot down a few things on your sheet of paper to remember things, but limit extensive note-taking. On the physical exam, think about the pertinent physical to explore. On most of these, you're going to be doing a heart-lung exam. You might be doing an abdominal exam on a lot of these. And then beyond that, be purposeful. Okay, there should be a good reason for doing the physical exam maneuvers that you are choosing. Develop your clinical reasoning, your hypothesis-based approach. And you will not perform any sensitive physical exams in these OSCE environments. You won't be doing a rectal or a pelvic or a breast exam, corneal reflex or throat swab. If you want to do some of those things, you can actually include it in your post-encounter note saying, hey, I want to do this as part of the workup. Other physical exam pearls: wash hands before and after the physical, drape the patient and ensure comfort. If you don't know what that means, drape the patient, please review that with your preceptor this week and review your training from last semester. Ask permission when doing sensitive things. Explain exam maneuvers, especially if you're doing things that might be a little bit confusing, like looking in someone's ear or in their mouth or in their eyes. Just explain what it is you're up to. And never examine through a gown. I still see some medical students on the wards doing this, and even residents in the clinics and in the wards doing this. This is not good practice. So take the extra moment that it takes to loosen the gown and to place the stethoscope directly on the skin. In the closure, you're going to explain key findings. You're going to sit down for this, don't stand. Explain the differential as you understand it, and then talk about the plan for next steps. Ask if the patient has any questions, see if they're okay with the plan, if they have questions about the plan, and address his or her concerns. Now, you're also going to be doing a post-encounter note. You're going to step outside the room, you're going to get onto Beeline, and this is what you're going to write. You're going to type out the key history. What is the chief concern? What is the HPI? What is the past medical history? What is the review of systems? What meds does the patient have? Allergies, family history, social history. You're going to be documenting all of those things. You're also going to be documenting key exam findings. The physical exam, including vital signs, you're going to document. And then you're going to come up with the assessment with a differential diagnosis. You're going to say, the assessment and plan is blankety, blankety, blank. The differential includes A, B, and C, and here's why. You're also going to have a separate part of the post-encounter note that is simply the differential diagnosis. You're going to be given 3 rows. In each row, you write down the diagnosis that you think could be likely here. It's going to be in order of likelihood. So number 1 is for the most likely. Number 2, second most likely. Number 3, third most likely. In the boxes next to it, you're going to see history and physical exam. What you're going to do there is you're going to list for each row what history supports that diagnosis. And then in each row, what physical exam finding supports that diagnosis. You can take physical exam findings from the vitals or any part of the physical that you did. You're also going to get an opportunity to list diagnostic tests that you want to do, which could include labs, it could include studies, it can include sensitive exams. Be specific. So it's not enough just to say, do blood work or do the CBC. You should say, check for a hemoglobin or check a creatinine or check a white blood count with a differential. Use technical terms for procedures, not general lay terms like blood work. They should be technical medical terms because you're communicating with the medical team in the post-encounter note. And in your assessment, what you're going to get back is history checklist, physical exam checklist, and communications checklist. We're going to have specific maneuvers, specific questions that we think are important for this specific case in the history checklist. We're also going to be looking for specific maneuvers we think are necessary for the specific OSCEs you're doing. Also, making sure you washed hands before and after the physical exam. Make sure you draped. And for the communication, make sure you did things like patient-centered interviewing skills, didn't interrupt, summarized, recognized emotions, things like that you have already been learning and you're getting really good at. This is just a quick list of the communications checklist. So freeze this if you want to review it. It's the same things you've been seeing already in seminars and in your intro to focused H&P. After the OSCE, you'll be sent your checklist scores, your post-encounter note. We'll send you an expert post-encounter note so you can compare yours to what we think is good. And then we'll also be sent a link to your video for self-assessment and a link to your precept, and the link will also be sent to your preceptor. The week after you do the mid-semester OSCE, we will be asking you to review your own videos, and in a separate communication, we'll tell you what to do with that. Bottom line is, good luck. Keep striving to improve your clinical skills and have fun with this. Okay, you guys are really developing wonderfully. I've seen a lot of your history and physicals already when you've come through the simulation center. So keep up the great work. Stay positive, stay optimistic, and strive for excellent clinical skills. The bottom line is you're doing all this to serve patients who are suffering and who need your expertise. So develop your skills so that you can serve them at the highest level possible. Take care, and please contact me if you have questions, and have fun with the mid-semester OSCE. Bye-bye.